Good morning, everybody. Sorry to be late this morning. And let's start with this presentation. I don't know what Oscar said before, but just run very fast for the general point of view. Cervical radiculopathy and myelopathy are very common pathologies in adult patients, and have been shown to cause significant disability and loss of productivity in our era. Surgical options include posterior decompression and fusion, but also anterior decompression and fusion, and cervical disc arthroplasty. To date, we know that ACDF is the most accepted treatment with satisfactory clinical results. Such a procedure is very effective in terms of resolving symptoms, improving their function, and restoring the physiological curvature of the cervical spine. It has been shown that fusion may alter the normal biomechanics of the spine, which may result in acceleration of the adjacent segment degeneration. And this problem has stimulated the search for the new motion preserving procedure, such as the introduction of the cervical disc arthroplasty. CDA has been shown to be beneficial in terms of preserving motion of the cervical spine and the possibility in reducing the adjacent cervical level degeneration. However, some controversy exists as to which could be the ideal surgical treatment in patients affected by multilevel cervical disc disease, and this is the topic of this presentation. And hybrid surgery that incorporate ACDF and CDA at different levels can be considered a possible option. The purpose of this combination is taking the advantage of both techniques in terms of vertebral stability and spine motion preservation. This is a first experience made some years ago, but the results are very good and the study is already ongoing. And 20 consecutive patients were treated with hybrid surgery and were prospectively enrolled. The surgical database was queried to identify 20 patients treated by ACDF and matched with the 20 CDA patients corresponding to the same levels of the operation. Inclusion criteria were degenerative disc disease with symptomatic radiculopathy or myelopathy at two contiguous levels from C3 to C7, and exclusion criteria were one or more than two vertebral levels requiring treatment, prior spine surgery at the operative levels, severe facet arthritis, ossification of the PLL, lack of motion or stability at the level of surgery, fracture, infection, tumors, osteoporosis, and so on. Preoperative feature. Presence of motion on preoperative dynamic X-ray was an element in favor of CDA. If no motion of the target level was found, ACDF was preferred as technique. In case of radiographic scene of stability, translation instability more than 2 millimeters, ACDF was chosen. When advanced vertebral body spondylosis or facet degeneration was observed, fusion was also chosen. So patients received CDA and or hybrid surgery if both or at least one level meet the criteria for arthroplasty. In hybrid surgery cases, CDA was performed at the mobile and non-spondylotic segment. The surgical procedure is the classic surgical procedure with a right-sided approach. For ACDF, I used to use the ROA-C cages from LDR Technologies. And for CDA, usually ProDisc-C or MobiC can be employed. In my experience, they both work very well. In this short video, you can see the insertion of the prosthesis inside the space. ACDF has already been performed in the lower level. And after that, the surgery is concluded. So these are the post-op control for the different groups. And what we studied the demographic data, intraoperative details, post-operative details, pre- and post-operative functional score, radiological findings, and complication. Clinical and radiographic data were collected on the last day of hospital stay at 1, 6, and every month. So as concerned the pre- and post-operative functional score, some outcome measures were assessed like medical outcome score study, 37 item short form health survey, the neck disability index, the VAS score for neck and arm pain, and Japanese Orthopedic Association score for myelopathy. For radiological findings, the range of motion was measured on dynamic full flexion and extension on X-ray. Also, the disc height was measured. Degenerative changes were assessed, and the evaluation of the interbody fusion was measured according to the Bidwell classification. The results. All patients had a minimum of 36 months follow-up, and comparative number of patients presented with myelopathy preoperatively. In each group, all patients had 2-level surgery. The preoperative functional score were similar in all groups without difference. So the median duration of the operation was shortened in ACDF when compared with hybrid surgery. The length of hospitalization was similar in all the groups. The hybrid surgery groups returned to work faster when compared with both SCDF and CDA. We don't know the meaning of this result. So VAS, SF37, Japanese score, NDS score improved equally in all the groups. I said something laughing? Okay, okay. So the range of motion increased significantly in CDA in hybrid surgery as compared with ACDF. The mean disc height was restored in all the groups. At 3 years follow-up, fusion was successfully achieved in fusion and hybrid surgery group. No patient undergoing hybrid surgery or CDA presented with the heterotopic classification, ossification, and the 3 groups had similar function improvement at 3 years follow-up. So this is a case, an illustrative case. This was a 45-year-old man with 3-year history, a numbness, a weakness in both hands, and with the left prevalence. This is the MRI showing in a problem with in C5, C6, and C6-7 disc herniation. The preoperative disc height was measured, and this is the results. The post-operative disc height was increased, and the range of motion was 48.2 as assessed on flexion extension lateral radiograph at 2 years follow-up surgery. The patient was discharged on the post-operative day 2, and she returned to work free of symptoms following 13 days. So which are the main features of this technique? Duration of surgery was significantly shorter for ACDF, as we said before. All the outcome scores were improved in all the groups. Cervical range of motion increased in CDA and hybrid surgery groups. The mean disc height significantly was restored after surgery in all the groups. Hybrid surgery group returned faster to work when compared with the other groups. So the point is that when selecting patients for hybrid surgery, some factors should be considered. First, degenerative disease may render motion at that level unpredictable. Spondylotic spine is often associated with multiple liver disease, and not all the affected liver may meet the criteria for CDA. Hybrid surgery can be an alternative to multi-level ACDF or multi-level CDA. The main role of hybrid surgery lies in restoring or maintaining motion where appropriate, or promoting bone fusion when indicated, by the extent of the degenerative changes and hypermobility. Hybrid surgery should provide a balance between both ACDF and CDA in terms of both intraoperative and postoperative results. This is a short overview of the literature showing the papers published, but more now can be found in the literature. And in conclusion, the findings suggest that hybrid surgery construct is safe and effective surgical strategy for the compression in patients with the multilevel cervical disc disease. Studies with the larger sample size and longer follow-up period are required to confirm the results of the present study. Thank you.